So I promise you we'll get to the NGS testing section of this panel. I knew it would evolve in every way back to testing, which is so important, which is part of the base of the story here is how we test, how we identify, who we test. We'll get there in due time. But first, let's talk about the data. We've now identified these fusions. They're rare. They are driver mutations, as Philip just mentioned. We've had a crowded space similar to the ALK world in lung cancer, where we've got all these therapies coming in. Larotrectinib was first approved, FDA, November 2018. We have entrectinib, which is a ROS and ALK drug as well, but has activity in NTRK fusions. And then a host of other drugs, LOXO-195, cabozantinib, crizotinib. Just a quick question before we talk about the data. I mean, do these drugs all work the same? Are they just as active in TRK fusions as another one, or are there differences here? Anyone want to take that real quick?
I mean, we have lung cancer experience where it says not all the TKIs are the same, whether you're talking about EGFR or ALK. So, and even we can cite our own IO experience where the main IOs don't seem to be behaving the same way in exactly the same situation. So I would assume that they're going to be different regardless of how sterically, chemically they look with the figures, but they seem to have different.
Yeah.
But I would just say that there is sort of two groups here of the drugs you were just talking about. There are these sort of second generation ones that, for the most part, are much more narrowly targeted, versus ones like cabozantinib and other ones, regorafenib, that hit VEGF receptor 2 as well as multiple other things, because it's important as far as when we get into toxicity profiling that you consider those two things. So I'd say it's sort of make it into two classes is probably the best way to start. We have the ultra specific ones versus the ones that are hitting multiple.
That's exactly how sort of ALK and crizotinib came about,
exactly.
Right? Crizotinib, the first target was not ALK in the IC50s, et cetera. It was MET and RON, and it was dirty enough that it hit ALK, and so it worked. And so, yeah, I think it's a very similar example of how we've looked at it.
I've just been very impressed with the drug development in these rare spaces. I watched the GIST world. I mean, okay, so first we discover GIST on the backs of a drug, and I thought, why would we ever need another one? Because that was the best one. And now we have lines of therapy in GIST, and so that's a relatively common disease compared to these fusion abnormalities, and yet we're already seeing sort of who's got a better product. Are there different subtypes of these? Will there be resistance that emerges, and how to, just like you lung people have taught us in the EGFR space. So I'm fascinated that when we get one of these things by the tail, we don't let go until we've really optimized the therapy.
I mean, the other issue is the toxicity.
Yeah.
Because if you have off-target effect, which you're going to have more and the dirtier the drug, that may well be one of the differentiators of the drug.
This is not dissimilar. So when you mentioned GIST, and I do treat GIST, this is not dissimilar to what happened with GIST. So we don't say anymore that someone has a GIST. Now you actually figure out what their mutation is, and then you specifically go to the exon, you're figuring out what part, and you really break it down further. You know what drugs works for which ones. And I think that will evolve with this as well. And so we'll start to see what NTRK 1, 2, 3, we'll see which is better. So the model just keeps applying from disease to disease. And it just keeps breaking it down, and the therapies get more effective as we break it down. It's fascinating.
Well, and I was also going to say some of the technically the off-target effects can also be therapeutic. So in thyroid cancer, we've really enjoyed things like cabozantinib, say in medullary thyroid cancer, because it had RET activity, but it also was a VEGF-R receptor inhibitor. So it was great for people who had RET mutations, but it was also great for people who didn't. Yeah. And so sometimes it's a sort of a love-hate relationship with those more broadly targeted therapies.
I've been impressed with these, as John mentioned, how many drugs have come into the space, but the difference between the drugs as the newer generations come out, from the ALK and the EGFR world, to see the next generation drug outperform the old generation has been impressive. It's been an impressive story.